repeat everybody's bio, but we are going to, I'll give a very quick introduction, and we'll have my great colleague, Telesphore Kabore, calling from Burkina Faso, who's my colleague on Save the Children. He's also part of Breakthrough Action. And I won't read the bios, you got them in the invite, but we've been working a number of years together with Telesphore. And then we've got Kate, who's a leader in the Frontline Health Worker Coalition, and also an APT team member and partner on the LHSS project. And Kate has a great expertise in human resources, and is going to bring us another flavor of today's discussion. And then we have David Bishai, who's a professor many of you will know at Johns Hopkins University, man of many talents, but he will intervene today as a discussant following Kate and Telesphore's presentations. And then hopefully we'll have enough time for Q&A. And as Jean suggested, and we'll remind you, you can type in your questions in the chat boxes, and we'll try to get through as many as possible. So without spending too much time, thanks again for our panelists and speakers for being here. I want just to have a word of introduction on today's topic. If I can have the next slide, please. So don't try to read this slide. First, the formatting got messed up, but also there's way too much thing for one slide. It's just a reminder that in the last 6 months, after many years of consultation, some of you probably were involved, but certainly colleagues from the MCSP, Core Group, USAID, partners of the ICHC conference, UNICEF, WHO, etc. We spend a lot of time making a case for community-inclusive systems for health model. And I won't be presenting it in details today, but you have the link to the paper, which has gathered some attention. So this is nice. And just to say what you will see in the paper is that you have like these salmon-colored boxes, which are roughly your typical building blocks of WHO's health system, which obviously now we emphasize a lot more the relationships between the blocks or between the functions, but those are traditional building blocks, set of inputs, considerations at policy levels to move forward. Those elements remain valid. And then in bluish gray color, you've got elements that we think need to be re-emphasized in terms of including community health systems into our views of health systems more globally. And I often use the language of systems for health to emphasize this point. And you will see that we consider in the model that our traditional 6 building blocks also need to include not only specific cadres for community-based services, and we all know about the recent WHO recommendations for CHWs, but they also require to have community organizations, which are a critical organic hub for community life and action at community level. We'll hear some of that from Telesphore, notably, and we'll hear from Kate about community health workers in another model. But also the paper makes the argument that we need partnerships, and we need partnerships as part of the central elements of the health system. And these partnerships can go in different directions. They can be multi-sectoral. They probably need to be multi-sectoral, but they also engage the private sector, and notably the nonprofit private sector, or what we often call civil society organizations. And then finally, learning system, information and systems need to become learning systems. That's a multi-stakeholder function. And there's a great deal of emphasis now on accountability. And those of you who have been, working with all these, coalitions that work on accountability are familiar with it, including with our working group and what we're trying to do actually through HSS. So I won't belabor the point of what is in the paper and the arguments it makes, just to say that those are big picture blocks, if you want, to stay with that metaphor. But if you go to the implementation level or a specific country, you could describe having these things in place as having platforms for community health. And if every time a project comes, you need to rebuild them, then obviously you don't have a platform. So the platform is a concept of something that is established and on which you can build different modalities of intervention. And we're going to hear about that in concrete terms from first Telesphore, then Kate, and then David will lead us into a broader discussion. So again, you may have questions and arguments about this model, and but I want to encourage us to focus on the specifics of what our panelists will bring, and then maybe have a look at the paper later and see to which extent it welcomes your own initiatives for building kind of sustainable, resilient, future-oriented community health platform. So I will now hand over to Telesphore. Remember, you can type your questions in the chat box to the host. And if we can have the next slide, and I'm handing over to Telesphore.
Thank you. Thank you very much.
I apologize, everyone. We seem to be having a problem with the audio. Please stand by as we correct this issue. And if you are having problems with audio, you can enter that into the chat as well. Telesphore, are you able to go?
Yes. Is it okay? Can I go?
Yes, please.
Thank you. So thank you, Eric. Thank you for the introduction, and good morning, good afternoon, everyone. I want to share maybe by 4 or 5 slides a few experiences that we had under the MCSP, the Maternal and Child Survival Project, the USAID Maternal and Child Health Flagship Program. And we had an opportunity to implement across various countries some community health, community engagement intervention. So I wanted to first present the framework for community health under which we implemented the activities, and then share a couple of slides on results we've harnessed from Bangladesh and Haiti. And my last slide will be about how we mobilize various community platforms to achieve these results. So next slide. So, you know, following the Institutionalizing Community Health Conference in South Africa in 2017, we kind of came up with this framework to summarize some of the conclusion of that conference. Just to say that when we say community health, we at least mean 3 things. You know, we mean the delivery of health services by a cadre of community health workers. But we also mean a set of interventions for social and behavior change, and all that supported by community participation, engagement, and therefore supported by community groups and community platforms. Next slide. So following that model, we had, as I said, across various countries under the MCSP era, implemented some significant community interventions. And for example, in Bangladesh, we were able to have, you know, significant changes in terms of health outcomes. And the community health approach contributed to the project's efforts to identify and reduce barriers to accessing health services, and contributed to changes in maternal and newborn and child health. The approach showed that it's possible to mobilize local assets and increase transparency, as well as increase accountability around local resource use. In this experience, by the end of the final quarter, 4 out of 5 districts had collectively set up an emergency transport system for maternal and newborn health care. The same proportion also met or exceeded their project's goal for the percent of births attended by a skilled doctor, nurse, or midwife. 4 out of 5 districts met or exceeded their project goal for the percent of women with home births who consumed misoprostol to prevent postpartum hemorrhage. And by the end of the project, more than 90% of the newborns whose births were assisted by skilled birth attendants in the Mamoni Health System Strengthening District received 7.1% Curexid. And the target percentage of newborn initiating breastfeeding within 1 hour after birth was exceeded across the 5 districts. So that experience in Bangladesh highlights the critical importance of meaningfully engaging community leaders in healthcare improvement intervention. In this instance, local governments removed barriers to service utilization, generated local resources, and strengthened public health facilities. The Ministry of Health of Bangladesh has taken up the Mamoni local government engagement model in 2 divisions of Bangladesh, covering more than 1,000 unions, where they are now providing targeted advocacy and sensitization meetings on the role local government can play in the health sector. In the case of Haiti, next slide. And similarly, we were able to exceed the target goal of pregnant women attending at least 3 prenatal care visits by 33%. You know, it was harder to go for the 4 ANC or even the now 8 that WHO is recommending. But if we kept the indicator to the 3 ANC visits, we had significant improvements. And in terms of newborn receiving postnatal care within 2 days of birth, that was also, we were able to achieve 63% and exceed the goal by 63%. And more than 8,000 additional newborns received checks beyond the target. Nutrition-wide, we also received significant improvement in terms of children under age 2 being assessed and referred in terms of their nutritional status. So next slide. So I wanted to take the rest of my time to kind of quickly walk you through how we were able to do that and what are the platforms that we engaged with and we capacitated, if I can use that word, so that they can locally in the different health catchment area conduct community collective action to be able to achieve these results. Typically, you know, we work with ministries, you know, following the health pyramid system, you know, having technical working groups at national level and trainers at regional level, but mainly at operational level, at the district level, building on the DHMT, the district health management teams, we expanded them to other line ministries and created what we call a multi-sectoral community engagement team or community mobilization team. And these are the, you know, the agile tendon of the work. These are the facilitators, those going village to village or health catchment area to health catchment area to engage communities, you know, conduct proper community entry process and facilitate community action plans development and implementation. So, and then in each health catchment area, that's what you have at the lower level here. We typically have the health facility management committee or the health committee, depending on the country where, you know, how they call them. But this is the community body that, you know, represents the community, you know, like the leadership or the governing body, who is the driver of the community collective action. And underneath or beneath that committee, you have various other structures or platforms that exist and that could be tapped into to conduct any other community intervention depending on their nature. So you could have care groups or support groups or village health committees or École de Marie, husband schools, and the like. And then based on the priorities that specific catchment area would have agreed to work on, local solutions are planned, implemented, and systems are put in place to coordinate community stakeholders' intervention, but also collect data to inform on the ongoing basis how they are making changes or how they can readapt their interventions to make sure that they are optimizing chances for success. So I will be more than happy to take some questions. I'm not wasting your time talking about challenges and difficulties, but I wanted to focus on how using a participatory process we can have some sound community mobilization processes to ensure that true partnership can be built between communities and the health system. Just to close the loop with the building blocks that Eric was talking about in his introduction. So I will stop there and I will be happy to take more questions when time for discussion.
Thank you, Teles4. And remind you can type your questions as they come in the chat box. And so Teles4 gave us kind of two examples of where community organizations were mobilized and involved at different levels to achieve change. We're now going to hear from Kate about a model that has evolved for some time and going through some evolution in the role of, in this case, the CHWs through the existing platform. So handing over to Kate. Thank you very much.
Thank you, Eric, and thank you, Teles4. And hello, everyone. I'm delighted to share with you our experience integrating NCDs into what I would call a mature community health systems model in Brazil through the Medtronic Foundation funded HealthRise program that recently ended. My name is Kate Green. I'm a Human Resources for Health advisor for the local health system sustainability project at Apt Associates, and I'm also steering committee chair for the Frontline Health Workers Coalition. Next slide, please. First, I'd like to give you some of the context regarding non-communicable diseases in Brazil to set the stage for the intervention of layering on NCDs to the community health platform there. The HealthRise project integrated NCD screening and treatment into the community health platform in Brazil, which Eric mentioned is something that has been evolving for some decades now. Now, we selected 2 intervention sites in Brazil, as you can see in the graphic here, one in Bahia State and one in Minas Gerais State. Both had local municipalities that were interested in partnering with us, and it's notable that in Brazil, implementation, service delivery of health is decentralized down to the municipal level. So there were 2 municipalities, Via da Conquista and Telefio Otoni, where we worked. And while Brazil has made progress in fighting NCDs and reducing its number of premature deaths, it still has a ways to go to meet its national NCD action plan. And one of the key issues for Brazil is lack of early diagnosis for hypertension and diabetes, with patients showing up at secondary, tertiary care facilities with complications. So this project, the intention was to address that, which was an issue in these specific municipalities as well. Next slide, please. So in keeping with the theme of the community health platforms and systems, one of the key elements for this work was engaging with the family health teams in Brazil. Family health teams, as you may know, are an essential component of the community health platform. This structure evolved from a vertical maternal and child health a program launched in the 1980s in Brazil with community health agents. And now community health workers are embedded in family health teams assigned geographically by catchment area and linked to the formal health system, the first facility, primary health care level. Now, interestingly, this is an interprofessional team that trains and works together. It includes a physician, a nurse, 4 to 6 community health workers that focus on prevention, surveillance, medical treatment. And this is a team that has a dynamic relationship with facilities, so informing facility planning and workflow. And in the case of this NCD project that was layered on to the family health teams, the work in terms of an interface between the community health teams and the facilities helped to rearrange some of the workflow to accommodate patients coming in at the primary level. So, for example, one of the things that the project was able to accomplish was collaboration with the municipal health department to make sure that patient flow, scheduling, and clinic time was organized in order to be able to accommodate patients coming in at the primary level. Next slide, please. As Eric pointed out on his slide, community organizations and societal partnerships were also key to this. It's not just the service delivery piece, but also patient organizations and universities were really key to this work. The Health Rise Project helped establish a formal patient association for people with hypertension and diabetes, which promoted self-care activities and also engaged in advocacy initiatives to improve policy and local health system capacity. And also the universities themselves were engaged. So, for example, Bahia State University signed a partnership for the university's specialized clinic to increase specialist appointments for patients who required visits in cardiology, endocrinology, and other specialties. Next slide. So here, I'd like to discuss some successes and lessons learned. You'll see in the chart here the improved health outcomes both in Vitória da Conquista and Telefio Otoni. We have the baseline in blue, the blue bars for hypertension and diabetes, and then the end-line results in orange. There was a formal evaluation conducted for the project, which found statistically significant reductions in blood pressure and glucose readings in Health Rise patients. So what you're seeing here is the difference from baseline to end line in terms of the patients meeting their targets. I'm happy to report that the NCD program continues to scale in Brazil and in the municipalities and states in which we worked. This has been continued by the local governments and then additional partnerships such as with the UK Medical Research Council. Also, we've heard that the clinics are continuing to provide dedicated consultation hours at the primary care level for diabetes and hypertension, and that the health system is maintaining continuing education on NCDs for health workers in the region. The challenges with health systems gaps, though, have continued. In the evaluation, there, despite this intervention and advocacy and the partnerships, there still were some issues with medication stockouts, staffing shortages, and barriers. Although the evaluation did note that the HealthRise sites did do better in these regards to comparison sites. And finally, since we're holding this webinar in the age of also responding to the novel coronavirus, I wanted to share that feasibility and feasibility assessments and flexibility are key. And note that this particular project was implemented during a severe yellow fever outbreak that especially impacted one of the project sites, Teofilo Otoni. So, you of course have to adjust the community health system platform, and health systems cannot do everything at all times. And this yellow fever outbreak particularly impacted the availability of nurses as part of the care teams at the community and primary level. The nurses and nurse technicians had to stop their normal functions to vaccinate the population, provide yellow fever immunization. So there was an interruption in nursing care for the chronically ill during this period. The federal government sent a national task force of emergency doctors and nurses to accommodate and provide care for yellow fever patients. And the regular health workers adjusted as best they could to continue care. Nonetheless, you can see that despite the outbreak occurring during this time, the other members of the family care teams were able to continue the work, and we still were able to achieve improved health outcomes in Teofilo Otoni, where the outbreak occurred. So thank you again. This is just a brief taste of the work that we did, and I look forward to hearing questions in the following discussion.
Thank you very much, Kate. It's very interesting to hear about a model that's evolved through the years. And again, keep sending your question in the chat box. So we're going to open our Q&A, but we're going to start the discussion by asking David Bishai to kind of give us, David, if you can give us kind of you recently published a paper we'll reference when we send all the links called Community Health Platform for Public Health Intervention. And I want to ask you to give us a little bit a historical perspective, which is in the chapter. It's actually a chapter, but there's a feeling from some of us that community health keeps coming back as an essential element of doing our work, but then somehow we keep having to argue and advocate for it. And I thought that maybe you could help us get a big picture responding to the two examples that were given by Telesphore and Kate about how we've evolved with this question. So over to you, David. Thank you.
Yes, thank you, Eric. This is David Bishai. First, let me make sure you can hear me, Eric.
Yes, hearing you fine.
Okay. So thank you for this opportunity, and thanks to both Kate and Telesphore for these terrific presentations. And in response to Eric's desire that we open up a much broader view, I'd like to give a long view of where community health activities like this have been going for the last several years. And while I'm speaking, I don't know if we could go all the way back to Eric's slide 5 about community inclusive systems, that conceptual model I think would be good to see as I try to put these presentations in context. So I would go back to the Alma-Ata conference of 1978 to sort of set a stage for where we've come from with these efforts. The Alma-Ata conference was convened in response to frustration that the health systems of the world were not reaching the most vulnerable. The health community in the 70s was frustrated. They had health systems that were largely delivering medical care in large urban hospitals and were not reaching the rural areas or the urban slum dwellers. And so when they gathered in Alma-Ata and produced the Alma-Ata Declaration, they asked for a pivot so that health systems would do what Eric's showing on his conceptual framework in blue. How can a health system do more to help households produce health and to help communities determine health better? That's on everybody's mind right now. With a coronavirus pandemic, you really do want to have households take the countermeasures and to have communities come together to stop the spread of the virus, as well as needing the hospitals to care for the sick. But we're weak on those systems still. So in the Alma-Ata Declaration, there was a lot of language on an attention to economic conditions and political conditions. There was a need to have all related sectors involved in the community. They specifically wanted housing and public works and communications. And they wanted community health workers to play a leading role going door to door, engaging people one-on-one with parts of the health plan. They wanted communities to be involved in control and planning and organization, not just a rubber stamp of, hey, your problem is XYZ and you must listen to us, but to treat people as adults and have them participate in planning and control. Now, the Alma-Ata Declaration did influence many countries in profound ways, and if you visit places like Bangladesh, Nepal, Sri Lanka, Cuba, you will see health systems that are deeply embodying community control. You'll see a lot of community health workers. You'll see the sorts of committees that Telesfor was describing, where there will be a village health committee, a support group that is actively engaged in thinking about how they can be healthy. So these presentations we heard today are very necessary because the Alma-Ata message was taken up by, frankly, a minority of countries. And most of the dominant strains of global health are what's familiar to us, where you get a donor who says the problem is hypertension or the problem is attended delivery, and I want to give you a targeted intervention to achieve these health outcomes, which look like how many people get antenatal care and how many hypertensives are getting their blood pressure under control. This targeted approach makes sense to a community of donor-funded interveners and ministries of health. But it can get the job done in a variety of ways. And one of the traditional ways has been called a vertical intervention, where you really don't need to engage the community and you just engage a WHO building block to go and just get the job done and not leave a structure behind called a community health platform. So our conversation today does have to reach the community with those marching orders. That's real. We have to deliver these commodities to fulfill our contracts, and we have this old way of doing things which isn't asking us to leave behind community platforms and committees. Now, these interventions in Brazil and Haiti and Bangladesh actually took the trouble to leave behind some structures of functional community health systems, and that's to their credit. But also notice that in their presentations, they had to appeal to us because no one's giving us contracts to build community health platforms. They're contracting with us to show numbers move on percent of antenatal care, to show numbers move on percent of hypertensives, and that's good because otherwise we'll keep with the old way. I think this year, as we see how a coronavirus epidemic requires us to build community responsive platforms to actually invest in our future preparedness and responding across multiple sectors. It requires agriculture and roads and animal husbandry and education, school systems. These are the sorts of responses that are being mobilized today, and frankly, most countries are realizing they were negligent. They were not taking their health sector using a community lens. Going forward, I'm hopeful that there will be a lot of attention to a community-inclusive system for health and more attention to get us the sorts of contracts that ask us to do that and to rate our progress on those fronts. So that's my reaction. I really am excited that there's been an appeal to, if we do community platforms, we can achieve our targets in the traditional sense of delivery. But in the future sense, I think delivery might change, and we might be asked to deliver a responsive and robust community response to whatever health challenges will come in the future. I'm looking forward to your questions, and we'll turn over the microphone now back to Eric.
Thank you very much, David. So we're getting a lot of good questions from participants, so thank you very much working with Sophie to kind of organize them. And I'd like to start fielding questions. Maybe I'll go in reverse order and get back to Kate, and then I'll ask a question to Telesfor. But the first question to Kate, and I'm trying to compile different things that are coming. Just a thing to say, we'll send links and everything to papers and documentations about the project after the webinar in a couple of days. So a lot of operational detail questions about the program design or the function of health workers in the case of Kate, I think will be better answered there. So, but to go to a big question for you, Kate, is, we can look at your presentation, your examples through the lens of a community health workforce delivering more services, and that's often how we think. But I think part of what's been interesting to me is the linkages that you described, internally within the health teams and externally with partners. So at the risk of giving you a leading question, how would you comment on the linkages, the relationships that were built that are part of what we define as these community platforms, and the importance in both performance and resilience of the health system? And if all the speakers can try to aim for 2 minutes max response to questions, that will allow to field more of them. Thank you very much. So over to you, Kate.
Yes, thank you for the question on the linkages. Well, my presentation did focus on the family health teams. We know that health is produced at home by the patients themselves, and then also requires these societal partnerships and community organizations. So I would go back to the fact that the linkages in terms of the patient organizations, where patients could be referred, and there could be peer networks and support for patients and family members to continue on treatment and engage in healthy lifestyles, and then also engage in terms of what was needed from the health system was important. Linkages in terms of expanding access to specialty care through the university partnerships. I'll also add that through the university partnerships, we were able to tap into medical students who could help accompany the teams and provide more support there. And then finally, I want to mention how important the relationships and linkages with the municipal government was. In order to conduct home visits, for example, to patients who were lost to follow-up or needed additional support, required a good data system and functioning internet at the health facilities. So working through that with the municipal government was really important to make sure that those systems were coming online too. So it was a very dynamic environment working across all of these partners, linking together to make this happen. Over to you, Eric.
Thank you, Kate. And I've got a follow-up question for you. I mean, I know that you've worked through the years with colleagues like Gail Snatro, Lisa Howard-Grabman, and a bunch of other great people. And you've worked on things called the community action cycle. And I know that the models you presented are not always necessarily exactly an implementation of that. But what this point out to me, and some questions to you from participants, were about evaluation. And just to tell people, we won't go in ex-post evaluation issues, but you can always email afterwards because there's an active committee of practice looking at ex-post evaluations. But tell us there's an inherent tension between evaluating what we get out of immediate interventions, like your first slides were about showing results that we got for MCSP, and those are critical, right? We reasonably can't be funded to implement interventions that don't deliver. And at the same time, the kind of second wave, longer achievements of building platforms and the relationship and more comprehensive processes that engage the community. So in 2 minutes, that's the challenge. What's your perspective on the challenges and the relative importance of bringing those two elements, the results and then the relationship, the platform building, in the evaluation of our community health interventions?
Yeah, that's a tough one, Eric. But I mean, personally, what I'm struggling with right now is what kind of evaluation design we can come up with to show how strengthening community capacity is. And by capacity, I mean certain dimensions like social cohesion, social capital, leadership, critical thinking. Showing how by acting on those dimensions of community capacity, it translates into greater health outcomes. So we still need to come up with methodologies and tools to be able to properly capture it. But in my practice, we often, at the end of the fiscal year, at the end of the implementation of the community action plan, we often try to have participatory evaluation processes with the communities themselves to see if the objectives they've set for themselves at the beginning were achieved, through the implementation of the community collective actions they carried out. So, and of course, it's not very sophisticated, but at least they want to increase uptake of ANC. Were they able to do it? Yes, no, why not, and all that, and then they weave that into the next cycle of implementation they will start.
Thank you, Telesfor. David, I'd like to field back one question to you. I mean, you wear a lot of hats, I find. And you've conducted and been part of very important research teams. I remember the work on the MDG goals achievement and so forth, and then of course the paper we referenced at the beginning. But these two waves of results that I was mentioning to Telesfor, how do you see investments? How do you see the challenge of making investments that both advance the results, which is a kind of reasonable mandate for public funds being oriented, or foundations, but also building these platforms? Like, are we facing a kind of a tragedy of the commons? Some people at WHO are speaking about common goods now. Is this an example of that? How do we balance these investments from a global perspective?
So that's a great question. Back during the height of the AIDS epidemic, there were many people that were quietly worried that the hyper-focus on one disease was drawing down resources from maternal and child health and primary care in order to turn people into really just HIV treatment specialists. That type of concern that a too intense focus in one dimension can erode the health system's capacity, that's still there. So there are some ideas floating around. None of them has really taken off, but one idea would be that if you are coming in with a funding for a single disease focus and you are drawing down resources, and we can show that you're pulling resources from the infrastructure of the health system for your focus, shouldn't a Ministry of Health levy a health system user fee to the donor, saying if you want to come in and reorient our services towards, let's say, vaccines or family planning, you have to pay into generalized health system strengthening, and we have a credible approach. Obviously, the worry is that the health minister would just take the money and do something ineffective with it. But imagine that there was a credible approach to health system strengthening where we had measures, not a performance in the traditional way of numbers of people getting a particular product, but measures of the capability of communities to have control, measures of intersectoral coordination in the health system, and that we're smart enough to measure health systems as systems. One particular approach would be that the health minister would build quality improvement teams and have them with the task of, is our health system really focusing on its ability to adapt to current problems. But a user fee, if you are using the health system for your particular problem, you need to build us the primary health care approach, and we will have a credible way to do it. That type of subsidization is really necessary. It's already happening in healthcare. Whether you know it or not, every time you go to the hospital and pay your bill, some of your money is being used by that hospital for a quality improvement team that is trying to emphasize patient safety. And the hospital takes your money and does things with it that are generally helpful to the hospital's resilience as a system. Well, why can't a Ministry of Health build that into its funding mechanism? But the start is for us to think seriously about measuring the system's health of these ministries and their ability to practice community-based healthcare.
Thank you, David. So I'd like to go back to you, Kate, and so there were some questions about the specific roles of the CHWs, how this evolved, and why they did that task versus this task. But let me rephrase it as saying, since we're both in the LHSS project, and I bring the community health accountability focus, you bring the human resource focus. But in reality, if we're going to do our work correctly, we're going to have to link all these pieces. So how do you see, your focus was on the health workforce at community level in Brazil with Medtronic, but how do you see the role of other components of the health system making that function, the health worker function, effective to achieve the desired changes?
Thanks so much. So just to share some ideas in terms of, if I'm getting your question around the functions and changes required in human resources for health to make this type of platform a reality. One thing that I think is happening in many countries and happened in Brazil in the 90s is that these community health agents were recognized as a healthcare professional and part of the health system. And actually that happened in 2002. So the recognition of community health workers within the Brazil context as part of the health system was really a key milestone in this type of integration and building a more resilient platform. And then I also think that having this cadre embedded within a team that also includes a nurse, physician, Others support teams that could include nutritionists, social workers, depending on the context of the specific populations. This interprofessional approach, I think, is very important so that all the cadres can recognize each other's roles, what they have to learn from each other as part of the community. Is really key. So the fact that they work together, train together, plan together, that formalized function was also very important. Over.
Thank you. I'm trying to balance continuing threads and trying to address as many questions from participants, and we're getting questions in many different directions. So I'll keep trying, but those are very good points. So at the risk of changing gears a little bit sometimes in the question, Telesfor, I want to ask you now, I mean, there's a lot of questions about how this kind of approach improve data use, how they improve information, even not just on community health, community-based activities, but health facility activities, and even some questions about how, what's the likelihood, what's the big sustainability question. But so I want to ask you, in your experience and in his experience in the two countries where you shared, what do you see as a prospect for continued progress by having built these platforms, and how would you compare that with the possibility of continued progress without the elements of platform that you have built? So rather than say, is it sustainable? The question is, how does its sustainability compare with having focused on one thing at a time rather than putting everybody together? So I keep increasing the challenges to you, Telesfor, but you're a good man.
No, right now, I have, my thinking is evolves around three key factors here. For me, one is, how do we ensure that within the health system, we weave into that some indicators and performance criteria in relation to the community health platform. Because when you look at the health system as it is, there is no obligation or push. No health facility performance is measured, no DHMT performance is measured based on the functionality of its community platform, based on how well communities are participating or have control over their health, to borrow the words from David. So for me, there is a great deal of work to do to see how we can weave into our performance measurement criteria in relation to what we are just talking about. And second, I'm looking at this big movement about decentralization, in particular in Africa. There are certain competencies that have been transferred to local municipalities. And there is a great deal of planning and budgeting at local government level, municipality level. And I think we need to wake up and see how we can weave into that movement the work that we are doing in terms of community health, because municipalities are focusing on building constructions and all that. But again, these interventions for social behavior change, community participation, and the like, are seen as the right processes to fund and to carry out. So I'm looking at the future of what we are doing in those terms. How do we take advantage of this movement and make sure that the system can self-fund or self-sustain itself? Over to you, Eric.
Thanks, Telesfor. No, that's a good point. Sorry, I've got my eyes on two screens. But there was also a question on how engagement with faith-based communities through these different models. And I'm going to allow myself to fill this one, because I think that's one of the arguments for building platforms, like not single-use health workforce or single-use, oh, here we are, let's organize a community group, but saying, let's build an organic let's contribute to the organic processes and help just guide them if we can. But because community groups in different societies will have different relationships and embeddedness in faith-based organizations. So I think the ideal platform is that it's going to tap into social, cultural groups and allow to kind of have this connection. And I think that's a great illustration that our problems are not lower middle income country problems, they are global problems. Because if you look at rich countries like the US, France, Switzerland, and some of the health systems failures that we have, even in these areas, we're at the point of asking, how do we reach into the communities? And maybe not having built these platforms, even in rich countries, is part of what hurts us. I wanted to have, we're going to run out of time soon, so I wanted to ask the last question to David very rapidly, and maybe it's a bit of a loaded question, but you wrote in your paper that without initiative to help community health platform flourish around the world, the health gains promised by interventions will cost more and deliver less. So I want to ask you a very biased question. Is the building of, and obviously, you know, I've been brought to this project I've mentioned a couple of times to help work with colleagues like Kate and build a platform for health. But my question to you is, how do we make the argument that strengthening these community health platforms is a health system strengthening intervention?
Thanks for the question, Eric. I think that the prior question on the faith-based communities is one of the angles. It certainly is strong for the health system to be able to draw on resources that it doesn't have to pay for. And one of the things that emerges once you take a community approach is that assets show up and start doing your work for you, and you don't have to put it on your budget. And simply indicating, once you have gone through a process of convening the community, you'll find that school systems will help you with your health education. You'll find volunteer groups would be doing some of the community built environment modification. You'll find neighbors checking on neighbors. Simply documenting and going to an asset-based approach should help people realize that the health ministry doesn't have to pay for all of the things we need to make our communities healthy. And that the approach of paying health workers every time there's a health problem is really not the best use of resources. So simply when we are doing these community systems, really being mindful of how many new assets are being mobilized to help make people healthy. And if you look around yourself right now as your community is responding to coronavirus, you'll see that in practice. You will see so many groups that are now helping with this epidemic that are not on the payroll of any health system. Over.
Thank you. So thank you very much, David, and thank you, all our colleagues. Our time is coming up, so just to remind you, we will send a recording and links. We will send links to the papers. Sorry for the questions we didn't take, but I think it's been a great discussion, even though we covered kind of the focus on health workers, the focus on community groups, and the big picture. Thank you very much, all of you, for joining. We'll send the links and updates through the apt newsletter. Make sure you join that. And I really think this, David called it as a conclusion, this asset-based, as being an economist. I say, you know, starting from where we are and the big emphasis on adaptive management as an area for our directions to do better transitioning, to do better system strengthening and building ownership. So thank you very much, everybody. Thank you to Kate, thank you to Telus4, and thank you to David. And thank you for my colleagues at App behind the scene who've been facilitating all this. And stay safe out there and socially isolate. Huh? So thank you, everybody. Bye-bye.
Bye.